In most cases, atherosclerosis is preventable because many of the factors that contribute to its development are modifiable. Assessing your risk and making appropriate dietary and lifestyle changes are key. Atherosclerosis is a complex multifactorial process, so you could check out my videos on cholesterol, high blood pressure, homocysteine, stroke prevention, diabetes and glucose control for more information. A healthy diet contains plenty of vegetables, fruits, nuts, whole grains, fish, and less processed foods, refined carbohydrates, and sweetened beverages. In addition, a diet rich in pro-inflammatory omega-6 fatty acid and deficient in anti-inflammatory omega-3 fatty acids promotes inflammation and oxidative stress, and this has been linked to numerous age-related diseases. A recent large meta-analysis examined over 45 prospective studies, and it determined there's a large, strong and consistent body of evidence to support the benefits of the Mediterranean diet on cardiovascular health. The Mediterranean diet has consistently been shown to reduce the risk of atherosclerotic cardiovascular disease. The diet, which is low in animal products and saturated fat, and high in olive oil, legumes, fruit, vegetables and fish, has been shown to reduce the risk of heart attack, stroke and dying from cardiovascular disease by around 30%. In a recent prospective cohort study of nearly 26,000 women in the US, those with the highest intake of Mediterranean foods had a 28% reduction in the risk of cardiovascular events. This was mostly attributable to reduced biomarkers of inflammation, glucose metabolism, insulin resistance and adiposity. A pesco-Mediterranean diet is a traditional Mediterranean diet but with an emphasis on consuming fish or seafood at least 3 times per week, and also removing all processed meat from the diet. In the pesco-Mediterranean diet, seafood is the predominant source of animal protein, providing omega-3 fatty acids along with zinc, iodine, selenium, B vitamins, calcium and magnesium. Although there's currently no evidence for adverse outcomes associated with high levels of fish consumption, low mercury fish should be eaten when possible. The seafood component of the pesco-Mediterranean diet might offer benefit over a solely plant-based diet. In a study on more than 48,000 people, the pesco-vegetarians, who consume the seafood as the primary source of animal protein, had a 13% lower risk of ischemic heart disease than the meat eaters. Vegetarians had a 22% lower risk of ischemic heart disease, but also a higher risk of stroke than the meat eaters. Some experts suggest combining the pesco-Mediterranean diet with time-restricted eating, and this might be optimal for the heart health. The time-restricted eating is a form of intermittent fasting, and it typically limits the intake of food to a 6 to 10 hour window during the active phase of the day, after an overnight fast of at least 12 hours. The insulin levels are lowered and the carbohydrate stores are depleted. At this point, fatty acids from fat tissue are metabolized instead of the sugar, and this can improve the insulin sensitivity. Several preliminary studies have suggested time-restricted eating offers some cardiometabolic benefits, particularly for obese individuals. However, rigorous studies on the benefit of intermittent fasting are uncommon, and a randomized clinical trial published in September 2020 failed to show benefits in overweight and obese individuals. Research indicates the ideal dietary ratio of omega-6 to omega-3 fatty acids is 4 to 1. However, the typical Western diet has a ratio of 20 to 1. Most people have a diet deficient in omega-3 and too high in omega-6 when compared to the diet that humans were evolved to have. This change in the dietary composition parallels the rise in overweight and obesity in the Western society. Elevated levels of omega-6 polyunsaturated fatty acids and higher omega-6 to omega-3 ratio promotes many chronic diseases, including cardiovascular disease, cancer, asthma, and autoimmune disease. American adults average 6 to 8 hours a day sitting, despite the well-known association between being sedentary and the increased chance of developing and dying from cardiovascular disease. Regular physical activity has been shown to be beneficial in those with atherosclerosis. Formal protocols called cardiac rehabilitation, supervised by medical practitioners either in a medical practice or at home, are encouraged. Do-it-yourself programs are also beneficial. The American Heart Association recommends at least 150 minutes per week of moderate intensity activity, or 75 minutes of vigorous intense activity. Moderate intense activity includes brisk walking, biking at a speed of 5 to 9 miles per hour, dancing, active yoga, recreational swimming, or any activity that puts one near but not past the point of being unable to speak a complete sentence without pausing for breath. Examples of vigorous activity are jogging, biking at speeds of greater than 10 miles an hour, resistance training, and swimming laps. Resistance training includes muscle strengthening tasks like weightlifting or the use of elastic bands or one's own body weight to improve the body strength. In some cases, this type of activity improves the lipid profile beyond what aerobic activity alone can do. In addition to a physical activity program, individuals should combat a sedentary lifestyle by increasing daily physical activity, by keeping busy with household work, gardening, and taking the stairs instead of the elevator. A 2021 study in 305 participants with peripheral arterial disease found high-intensity walking, defined as a pace that elicited ischemic leg pain 5 times per week for 1 year, increased the 6-minute walking distance by an average of 35 meters. By contrast, those who were assigned to the low-intensity walking exercise or no exercise did not experience the improved 6-minute walking distance. The authors of the study concluded the patients with peripheral arterial disease should walk for exercise at a pace that induces ischemic leg symptoms in order to get a benefit. Tobacco use is a major modifiable risk factor for many diseases, including cardiovascular disease like coronary artery disease, stroke, vascular disease, congestive heart failure, angina, and aortic aneurysm. Smoking cigarettes is a causative factor in approximately 1 in 5 deaths in the US. It's known to damage the heart and the blood vessels and to elevate cholesterol and blood pressure levels. It also prevents oxygen from adequately reaching all of the body's organs and tissues. And research suggests cigarette smoke causes oxidative stress, vascular dysfunction and inflammation, platelet coagulation, and it impairs the serum lipid profile in both active and passive smokers. Those that use tobacco should strongly consider quitting. The process of quitting can be different for each person, and it should be individualized. However, successful quitting most often involves a combination of tobacco cessation, counseling, and nicotine replacement. There's also herbal remedies that can help. Any level of exposure to tobacco smoke is harmful, and non-smokers who are regularly exposed to secondhand smoke are at risk of developing cardiovascular disease and stroke, and even a brief encounter with smoke may be harmful. There's some evidence that light drinking might be heart healthy. However, the evidence is relatively weak, and it's based on observational studies and not controlled trials. It's not generally recommended to start drinking alcohol for any perceived benefit on atherosclerosis. For those who do partake, light drinking should be emphasized, limiting the consumption to 1 drink per day for women and no more than 2 drinks per day for men. People with a very high LDL, diabetes, and between the age of 40 and 75 have an elevated risk of cardiovascular disease, and they may require more aggressive cholesterol-lowering strategies. Reduction of total and LDL cholesterol by drugs usually involves inhibiting cholesterol production in the body, or preventing the absorption and the reabsorption of the cholesterol from the gut. When the availability of cholesterol to the cells is reduced, they're forced to pull cholesterol from the blood. This has a net effect on lowering the LDL cholesterol. Therapies that increase the breakdown of fatty acids in the liver or lower the amount of VLDL in the blood also result in lower serum cholesterol levels. Often complementary strategies like statins to lower cholesterol production plus bile acid sequestrant to lower the cholesterol absorption are combined to meet the cholesterol lowering goals. Aspirin has long been used to prevent heart attacks and in those who are at risk of cardiovascular events due to its role in preventing thrombosis, which is the underlying cause of heart attacks. Recent large-scale studies have helped to redefine the group of people who are most likely to benefit from aspirin therapy. The European Society of Cardiology does not recommend aspirin or aspirin-like therapy for individuals without established cardiovascular disease, and the American Heart Association states that daily low-dose aspirin might be considered as a preventative measure among a select group of adults aged 40 to 70 years of age who are at a higher risk of the cardiovascular disease, but not at an increased risk of bleeding. Current evidence suggests the aspirin is not helpful for primary prevention of cardiovascular events among people with low baseline cardiovascular risk. The American Heart Association indicates that daily low-dose aspirin should not be used on a routine basis to prevent heart disease in those older than 70 years, and not as a preventative in adults of any age who have a history of abnormal bleeding, stomach or intestinal ulcers, low blood platelets, those who use medication that increases bleeding, such as anticoagulants or other blood thinners, and those with certain other medical conditions. In addition, the aspirin therapy is not appropriate for those who drink alcohol on a regular basis. Recent research has demonstrated an increased risk of major bleeding episodes, and recent trials have failed to show that aspirin was effective for preventing major cardiovascular events, including heart attack and stroke. An observational study tracked over 33,000 people with atherosclerosis, and it found that aspirin was only slightly beneficial for those with a history of heart attack or stroke, but not beneficial for those with no such medical history. In another trial, adults with diabetes but not cardiovascular disease randomly received either 100 milligrams of aspirin per day or placebo. More than 15,000 subjects were followed for over 7 years, with the primary endpoints being serious vascular events such as stroke, heart attack, or death from vascular causes, or major bleeding events such as serious bleeding or hemorrhage. And the researchers found the aspirin prevented vascular events in those with diabetes but not cardiovascular history, but it also caused major bleeding events. In another randomized, double-blind, placebo-controlled, multi-center trial on over 12,000 men aged 55 plus and women aged 60 plus, with an average cardiovascular risk, received either 100 milligrams of aspirin per day or placebo. The researchers were not able to conclude that the aspirin was more effective than the placebo at preventing a major cardiovascular event, such as cardiovascular death, myocardial infarction, unstable angina, stroke, or a transient ischemic attack. In yet another randomized placebo-controlled trial, over 19,000 people aged 70 years and older received 100 milligrams of aspirin for 5 years to determine if the aspirin had an impact on death, dementia, or physical disability. And the researchers concluded the aspirin use did not prolong the disability-free survival, and it led to a higher rate of major hemorrhage when compared to a placebo. The American Heart Association provides atherosclerosis treatment guidelines to healthcare providers and their patients, and these guidelines are intended to prevent fatalities from atherosclerosis, non-fatal heart attacks, and damage to heart function, which could lead to heart failure. One cornerstone of the therapy is managing underlying conditions that lead to the onset and the progression. A multifaceted approach is recommended to modify the blood lipids, and this includes lifestyle elements, nutritional supplements, and pharmaceutical treatment. Daily physical activity is advised, and weight loss is encouraged, as a 10-pound weight loss is associated with a lowering of LDL cholesterol by 5 to 8%. Intake of saturated fats should be limited to less than 7% of the total calories, and trans fats should be avoided. Supplementation with plant stanols and sterols and viscous fibre have also been shown to reduce the LDL. For individuals with atherosclerosis who are identified as being of high risk, the LDL level should be kept below 70 mg per deciliter. This applies to those with multiple cardiovascular disease events or one cardiovascular event and multiple high-risk characteristics. Cardiovascular events include heart attack, near heart attack within the past 12 months, stroke due to plaque rupture, or any symptomatic peripheral atherosclerosis. High-risk characteristics including age older than 64 years, diabetes, high blood pressure, chronic kidney failure, current smoking and heart failure, among others. In those who have atherosclerosis and high blood pressure control is paramount. Lifestyle modification alone can be attempted first to see if the blood pressure can be controlled without medication. This involves weight control, increased physical activity, a diet low in sodium, lots of fresh fruit and vegetables, and low-fat dairy products. However, medication may be needed. I also have videos on herbal supplements that can help. The blood pressure treatment target might vary depending on the patient's established risk factors and the overall baseline risk. A review of studies examining aerobic exercise found regular moderate intensity exercise can lower the systolic blood pressure by about 3.84 millimeters of mercury and diastolic blood pressure by about 2.58 millimeters on the mercury. In people who are overweight, even a modest weight loss of 4 to 8% of body weight can lead to a 3 millimeter on the mercury drop in systolic and diastolic blood pressure. A review of studies that focused on the effects of excessive alcohol consumption on high blood pressure found quitting drinking or limiting alcohol to 1 or 2 drinks per day resulted in a 3.3 millimeter on the mercury reduction in systolic blood pressure and a 2 millimeter reduction in the diastolic pressure. Reducing sodium intake can lower the blood pressure by 3.39 millimeters and the diastolic blood pressure by 1.5 millimeters. A very effective lifestyle modification appears to be the DASH sodium diet, which combines a reduced sodium diet with one that emphasizes vegetables, fruits, and low-fat dairy products. In one clinical trial compared to participants in a high sodium diet group, hypertensive participants in the DASH sodium group experienced a reduction of 20.7 millimeters on the mercury for systolic blood pressure and 7.9 for the diastolic blood pressure. If a medication is needed to achieve the goal, then the most common pharmaceuticals employed are thiazolide diuretics, beta blockers and ACE inhibitors, or angiotensin receptor blockers. Certain medication is preferred under certain conditions. For example, beta blockers are favored in those who've had a heart attack, and ACE inhibitors are preferred treatment for individuals who've both high blood pressure and diabetes. For more on atherosclerosis, or herbs, supplements, and natural treatment plans, check out my website.